As a student clinician who is very interested in working in the acute care setting, I decided to closer examine the role of the SLP in the respiratory ICU, or RICU as I'll be calling it, especially as it pertains to artificial airways. This presentation aims to further describe our work in this setting, including the patient population with whom we will be working, interdisciplinary collaboration, different types of artificial airways, mainly the endotracheal or tracheostomy tubes, and ventilator dependency, and their correlates to voice and swallow with these patients. Clinical implications for both voice and swallow will include a discussion of diagnostic and monitoring procedures. Patients can be admitted to the respiratory intensive care unit for a number of etiologies, all that ultimately cause extreme pulmonary distress. For example, patients can have neuromuscular disorders, unexpected complications post-op, pulmonary disease, trauma, and a number of other diagnoses. Most, though not all, patients receive support from an artificial airway in the form of an oral or nasal endotracheal or ET tube or a tracheostomy tube. Endotracheal tubes are generally for patients who either require immediate intubation for airway support or who will likely require mechanical ventilation for a shorter amount of time. Most patients with an ET tube are heavily sedated and unable to breathe on their own. A tracheostomy tube is placed as an artificial airway for a longer amount of time, and although many patients with a trach are ventilator dependent, not all patients require ventilator support. When working as an SLP in the RICU, it's important to be aware of the team and the other health care providers with whom you'll be working. As with other units, physicians and nurses will be working on a team to care for the patient, but in the RICU there's also a very prominent staff of respiratory therapists to manage the mechanical ventilation of patients. Communication with the team is crucial in the setting due to how quickly the patient's status can change. And there are a few reasons that a physician might consult us for a patient in the RICU, and we always need to focus on answering whatever referral question may be. For a patient with an ET tube, we are usually added to the case to evaluate the patient's voice and swallowing post-extubation. We might be consulted to see a patient with a trach receiving mechanical ventilation or a patient breathing independently with a trach for both voice and swallowing as well. And these decisions are made by physicians and are monitored by nurses and respiratory therapists. And there are many different factors to consider when evaluating and treating a patient, which will be discussed in greater detail later in this presentation. The literature review portion of this presentation focuses heavily on preserving oral communication and swallow function in individuals with a trach or ventilator dependency. A note before beginning the review is that articles regarding oral communication are older than is generally preferred, but are still relevant because ASHA's position statement and guidelines for the use of voice prostheses in tracheostomized patients is from the early 90s as well. The first series of articles discuss oral communication in patients on a trach. The first article establishes that the population of trach patients is very large and has a diverse range of etiologies and duration of ventilator dependency. Here, Tippett and Sybins separate their research into preserving oral communication in individuals with trachs who breathe independently and then in individuals who are ventilator dependent. The source focuses primarily on unidirectional valves and begins by describing the history of their development, which begins in 1968. Unidirectional speaking valves work by closing off the cannula through different means, like using a membranous slat for the Passy-Muir valve or a small ball for the Hopkins ball valve during exhalation. The Passy-Muir valve, which is widely used in hospitals today for many different reasons, one of which is because its purple color makes it easily distinguishable from other tubes and plugs connected to the patients. By only allowing air to enter through the cannula during inspiration, the valve forces all the air from the lungs out through the vocal folds and larynx, which helps support speech. It's so important that if the trach has a cuff, the cuff needs to be deflated before placing the speaking valve, or else the patient won't be able to exhale and will suffocate. The aim of their research was to describe the process of deflating the cuff in patients in a rehab setting to improve overall quality of life through oral communication and increased swallowing ability. It's important to note that overall cuff deflation can have a profoundly positive influence on the quality of life. The patients seen by these researchers were not ICU patients and were much more stable than ICU patients. The second article reviewed, entitled Speech Production During Mechanical Ventilation in Tracheostomized Individuals, reinforces the findings from the previous article in that although many people in this population can function efficiently with a cuff down, patients are usually still fitted with cuffed and unfenestrated tubes, which makes it impossible to produce voice. Again, the patients in the ICU are usually incredibly unstable, so following the suggestions provided by researchers for ventilator adjustments and speech duration chaining may not be feasible in this setting. The next resource, titled Patients Requiring Tracheostomy and Mechanical Ventilation, was published in the ASHA Leader and presents a model for interdisciplinary care for these patients. Research emphasized the need to increase SLP competency with this population because medical advances have increased the number of patients who require a trach tube and increased drastically the number of people in this population. The researchers outlined an interdisciplinary protocol for evaluation and treatment of patients with trachs for rehab facilities. Though the longer-term goal in this setting is often decannulation, which is generally not as explicit focus in the ICU, the researchers continue to support the clinical benefits of cuff deflation across settings. Now moving from voice to focus more on the swallowing correlates. For tracheostomized patients, the first group of researchers in their study entitled Swallowing Mechanics Associated with Artificial Airways, Bolus Properties, and Penetration, Aspiration Status in Trauma Patients completed a retroactive regression analysis of more than 200 videofluoroscopic swallow exams to examine the associations between swallowing properties based on artificial airway and aspiration penetration status. Their findings supported previous research that supports the use of manipulating bolus volume and viscosity as an effective way to minimize aspiration penetration risks in more susceptible populations like those of trachs. And additionally, these researchers identified a decreased hyolaryngeal positioning in tracheostomized patients, but found that otherwise they had relatively typical patterns of swallowing mechanics. It's important to note that for this population, as military service members, the younger age of the population compared to the general population of the RICU might impact the generalizability of the study. But still, the tracheostomized patients in the study were largely able to overcome any effects caused by the tube to achieve a near normal swallow. And these findings indicate that even though an individualized approach is always best and should include an instrumental evaluation with these patients when possible, the clinical reality is that in patients pending instrumental evaluation, global exercises like an effortful non-bolus swallow or the Masako maneuver may be beneficial as a preliminary therapy until the swallow can be visualized and then a more personalized plan can be developed. This study also doesn't include the impact of a speaking valve, so further research needs to be done to study the confluence of voice and swallow correlates on tracheostomized patients. The next source regarding reducing pneumonia risk factors in patients with trachs. The researchers here identify many different clinical considerations for individuals in this population, and they acknowledge that although the long-term goal for many of these patients is to restore independent upper airway use, thereby removing the need for a trach, that the goal will likely not be realized while the patient is in the ICU or in the acute care setting in general. So therefore, our short-term goals for the ICU focus mainly on eliminating or reducing aspiration. Researchers cited previous studies which revealed that patients who have tracheostomies develop pneumonia at a much higher risk than patients without a tracheostomy, regardless of whether they are eating or drinking. So researchers then provided suggestions to reduce the risk of pneumonia, which include extubating and decannulating when possible as fast as possible. And importantly, these researchers noted that the presence of dysphagia is likely due to the underlying medical diagnosis and not due to the presence of a trach tube. They also supported the necessity of instrumental assessment as a method to reduce pneumonias caused by silent aspiration in this population. Now finally, the last and the most recent literature reviewed was an article just published in a recent National Leader on the importance of oral hygiene. Here, Scheffler argues that oral hygiene is viewed in the hospital setting as a low-priority comfort measure, but cites huge reductions in ventilator-dependent pneumonia with proper oral care as a reason to make it more of a priority in this setting. Clinical implications can be discussed from the perspective of both voice and swallow correlates, both of which we could get a consult for. Post-extubation referrals generally encompass a bedside voice and swallow assessment, and depending on the protocols of the hospital, an instrumental assessment also. It's common for patients to be hoarse following extubation, so the SLPs usually wait to determine if further intervention is required after seeing if it resolves itself when the edema goes down. If problems persist, the patient should be referred to an ENT to identify something like a keyhole lesion or granuloma or another iatrogenic effect post-extubation. The speaking valve evaluation on trach patients is a collaboration between the physician, the SLP, the nurse, and the respiratory therapist. Respiratory and phonatory qualities are first assessed with intermittent cannula occlusion by the SLP, usually with a gloved finger, and includes monitoring the respiratory rate of the patient, if they have shortness of breath, effortful exhalation, and voice quality. Remember that patients in this population are very sensitive and can change rapidly, so close monitoring is very important throughout this whole evaluation to ensure that the patient doesn't start to desat. If SpO2 levels decrease, usually lower than the mid-80s, or respiratory rate and heart rate increase too high above baseline, or the patient reports discomfort or appears to be short of breath, the speaking valve should be removed. Precautions are placed with a purple passy mirror valve to remind everyone that when the speaking valve is on, the patient's cuff must be down. The SLP should note how long the patient can tolerate the valve and monitor this closely through continued objective and subjective measures. Also, the speaking valve, again most notably the passy mirror valve, has adaptations that can be used for ventilator-dependent patients as well. As reviewed in the literature, deflating the cuff might be more advantageous than is generally believed in the RICU and can greatly influence a patient's quality of life by giving them the ability to communicate orally. And for these critical care patients, until definitive research and protocols are established, it's important to always consult the team before deflating the cuff. Now, focusing on the clinical implication for swallowing in the RICU, we will again look at patients recently extubated and patients on the trach, both with and without ventilator dependency. There aren't established protocols or guidelines to ensure consistency across hospitals, so consults in the RICU vary from hospital to hospital. Consultations also depend on a department's ability to market itself and establish a visible presence throughout the hospital. So for an example of a hospital protocol for SLPs in the RICU at Temple University Hospital, the SLP automatically receives a consult for a patient who is extubated and is supposed to perform a bedside swallow exam 24 hours post-extubation. Depending on the results of the screen, and also considering patient and caregiver input, information from the medical team, and a thorough chart review, the SLP then decides whether to assign a diet level or make them MPO until instrumental testing is provided. Since there isn't an established protocol, hospital protocol, as well as evidence-based research when determining your best practice is necessary. Though many researchers agree that instrumental assessment is a gold standard for evaluation, it's necessary to consider that cost, resources, patient mobility, and other factors could impede your ability to perform an MBS or FEES evaluation. Though there remains a debate over which is better, FEES or MBS, and which one is preferred for which patients, in reality, the hospital's resource and department protocol, in addition to patient mobility, will likely determine which instrumental assessment, if any, you're able to use on the patient. So following then, a blue dye test can serve as an aspiration screening before instrumental testing, or when a person isn't stable enough for an instrumental exam. ASHA recommends this blue dye test as a screening only though. The SLP adds blue dye to the bolus of food or liquid and then suctions through the cannula. Presence of blue secretions is an indication that aspiration has occurred, but it's also important to note that its absence doesn't necessarily mean that the patient hasn't aspirated. There are many clinical factors that are pertinent to swallowing and should be considered when evaluating or treating a RICU patient with a trach. Questions that an SLP might want to consider include if a cuff is present and what are the effects of the inflation of it. Sometimes an inflated cuff, especially an overinflated cuff, can cause irritation to the tracheo-esophageal wall and other negative long-term effects. When possible, deflation is beneficial for swallowing as it allows the SLP to access airway protection abilities through vocal quality at baseline, and then during the assessment through the presence of throat clearing, coughing, or a wet vocal quality following the assessment. ASHA recommends cuff deflation when medically appropriate because the cuff provides little protection against penetration or aspiration, unless thorough suction is accompanying consistently. And remember that the main purpose of the inflated cuff is to create a closed circuit of air in and out of the trachea and is generally not inflated specifically to prevent aspiration. Now, other questions that you might want to consider when evaluating these patients or doing serial testing is what the size of the tracheal tube is, and is mechanical ventilation used consistently? If so, are they weaning, and what is the ventilation mode? How long has the patient been there, and what is their condition like today? And also, as we talked about in the lit review, how is their oral care? Is there a toothbrush with suction present in the room? If so, it's within our scope of practice to use it before beginning the evaluation. So a further question you might want to ask, as we discussed before, is the impact of occlusion of the trachea through a finger or speaking valve on the swallow. In some patients, tracheal occlusion will improve swallowing because it reestablishes the subglottal airway pressure, but an SLP should perform the eval under as many different conditions of occlusion as possible to determine if it will improve the patient's swallow. But remember that the cuff needs to be down if you're doing this, so it's very important to consult the medical team. As discussed in the literature review, the overall goal for these patients in the RICU is the prevention of aspiration through diet modifications and exercises. We will receive consults to the RICU for primarily voice and swallow for patients post-ET extubation or with a trach. Though not specifically mentioned, cognition is interrelated with their ability to follow instructions and progress in treatment. And as always, it's crucial that we use our eyes and ears every time we enter the room, and especially with these generally unstable patients. When practicing in a hospital, remember that there isn't an established protocol for dysphagia management. And of course, don't forget that you're treating a patient, not a disorder, which includes education and counseling components for the patient and the caregiver. Though speech and swallowing isn't their primary diagnosis, it's still a very important aspect of their care.